Hello, today we'll be talking about a case that we encountered on the labor and delivery service at Henry Ford, Maine. So, our patient is a 38-year-old G3P1011 at 29 weeks and 5 days. So, on July 21st, she presented to clinic for evaluation of fetal cardiomegaly, small pericardial effusions, and concern for fetal anemia. So these findings were first noticed on an ultrasound on July 17th, a few days prior, and we'll go over that in a few slides. So in addition to these ultrasound findings, our patient was reporting that she had been experiencing moderate fatigue and progressive edema, as well as elevated home blood pressures up to the 150s over 100s. She denied any vaginal bleeding, contractions, or leakage of fluid and reported that the fetus is active. She also denied any recent illnesses, as well as shortness of breath, orthopnea, headaches, visual changes, or right upper quadrant pain. So next we'll talk about our patient's past histories. So her past medical history includes chronic hypertension, which began as preeclampsia in a previous pregnancy, as well as a history of postpartum cardiomyopathy, as well as a history of type 2 diabetes. Now, this type 2 diabetes resolved after her gastric sleeve surgery. Her past surgical history includes a low transverse C-section in 2015, as well as an appendectomy in that same year, followed by a combined abdominoplasty and breast reduction surgery in 2016, as well as gastric sleeve surgery in 2021, and this is what resolved her type 2 diabetes. Her home meds include aspirin, ergocalciferol, labetalol, nifedipine, and a prenatal vitamin. Her only known allergy is to lisinopril, and she has no significant family history. As for her social history, she says that she's a never smoker, and she denies any alcohol or drug use during her pregnancy. So overall, because of her history of preeclampsia and her multiple other comorbidities, as well as her symptoms of edema, elevated home blood pressures, and the ultrasound findings that we were going to talk about, we decided to admit her to L&D for observation.
The fetal ultrasound at 24 weeks and 4 days gestation on 7/17 showed 3 key abnormal findings. First, there was suspected fetal anemia, evidenced by an elevated middle cerebral artery peak systolic velocity of 1.57 multiples of the median, suggesting compensatory increase in cardiac output. Second, cardiomegaly was present with a cardiothoracic ratio of 0.67, which may reflect volume overload or underlying myocardial disease. Third, a pericardial effusion was noted, raising concerns for possible right heart dysfunction. At this time, there was no sonographic evidence of hydrops. However, the constellation of anemia, cardiomegaly, and effusion raised concern for progression to high output heart failure.
Next, we'll talk about some of our patient's labs as well as her overall hospital course. So as mentioned, she was admitted on July 21st with an elevated blood pressure of 153 over 105. At this time, she was noted to be anemic with a hematocrit of 32.6 and a hemoglobin of 11.1. Her platelets, liver enzymes, and LDH were all normal at this time, and her protein creatinine ratio was 0.29, which is slightly lower than the threshold of 0.3 that we use to call it overt proteinuria. Her albumin at this time was low at 3.4. A couple days later, on July 23rd, she was diagnosed with an intrauterine fetal demise. At this time, her parvovirus titers did come back as 5.77, so significantly elevated. A couple days after this IUFD, on the 26th, she continued to remain anemic with hematocrit at 28.6 and hemoglobin at 9.6, both of which were lower than on admission. Her platelets, liver enzymes, and LDH continued to remain normal, and her protein creatinine ratio did spike at 0.91. So this is up from 0.29 on admission, and it is well above the threshold of 0.3. Finally, her albumin was at 3, which is still low, and it's lower than on admission.
Based upon the radiology and lab findings, we will walk through a differential diagnosis. Fetal anemia. One important cause of anemia is parvovirus B19 infection, which was later confirmed on a torch panel and provides a clear explanation of the anemia. However, this diagnosis does not account for the maternal symptoms. The presence of fetal structural heart disease could provide an explanation for fetal cardiomegaly and pericardial effusion, though this would likely not elevate the MCA-PSV. Notably, also, NIST was completed earlier in the pregnancy, which showed low risk. Congenital infection. The torch panel did show positive IgG antibodies to parvovirus B19. The diagnosis of hydrops is made when there is fluid accumulation in 2 or more fetal compartments, including the skin, pleural effusion, pericardial effusion, or ascites. Hydrops alone, however, does usually not cause maternal symptoms unless the mother develops Muir syndrome. Muir syndrome is characterized by generalized maternal edema, often with pulmonary involvement, that mirrors the edema seen in a hydropic fetus. It is most often associated with non-immune hydrops fetalis, such as caused by parvovirus B19 infection. Some studies suggest that a hydropic placenta may increase tyrosine kinase production, which contributes to maternal endothelial dysfunction and vascular abnormalities. This can lead to preeclampsia-like findings, as were observed in our patient. Clinical findings. Symptoms may appear during the antepartum period and can persist into the postpartum period. Clinical features include rapid weight gain, peripheral edema, shortness of breath, and signs commonly seen in preeclampsia such as hypertension and proteinuria. Unlike preeclampsia, however, hemodilution is often present in Muir syndrome, leading to a low hematocrit and hypoalbuminemia, as demonstrated in our case. Delivery is the definitive treatment.